So he'll have the opportunity to share his story and his insights into colorectal cancer research, and we just really appreciate you as a medical advisor with the program. So thank you.
And Dr. Deming is actually going to be facilitating the next session as well. So for those who are panelists, Tom, Sara, Jane, we'll go ahead and have you come up right now too, just to keep that.
Thank you so much for the opportunity to speak to you guys today. The last 2 hours has been one of the most amazing sessions it's been the most amazing session that I've ever been a part of. I was basically crying the entire time, and this is the first time I've been to an event like this, and as a young cancer survivor, I can't tell you how much everybody sharing their stories really means to me on a personal level. And to be able to see, even as an oncologist, to be able to see other people, fighting the same fight, it's truly an honor to be here. So I did my medical training in Wisconsin and was fortunate enough to stay on as faculty there. And 2 weeks after I had already accepted a position as a colon cancer physician, medical oncologist, and a colorectal cancer researcher with my own laboratory, just 2 weeks after accepting that position, I myself was diagnosed with rectal cancer. Diagnosed with stage 3C rectal cancer. Underwent chemoradiation, surgery, and additional FOLFOX chemotherapy. This was just 6 weeks after my daughter was born, and I've heard a lot of people talk about how physicians miss their diagnosis. Well, I was that physician too. I had bleeding for over a year and didn't want to be the trainee / young oncologist who was forcing their gastroenterologist partners to do a colonoscopy for hemorrhoids. And so as hard as it is to say, I was probably my own worst enemy in this, despite seeing people going through similar battles on a daily basis. I learned my lesson, and I'm very excited to be able to share my story now and be able to kind of walk through this battle with my patients hand in hand. I had a very low cancer, and so I needed a permanent ostomy with APR. And as many of you have described as well, this experience in the end has now been a blessing to me. So now 3.5 years out, I can look my patients in the eye and say, I've been there. I know what it feels like to hear the cancer word. I know that nobody wants to have an ostomy, but life doesn't end after an ostomy either. And so about 3 months after I was diagnosed, I had a patient come to me from 6-7 hours away because he didn't know what to do. His oncologist had told him that he was going to need an ostomy, and just the thought of having an ostomy was more than he could bear. Had a potentially curable colon cancer or rectal cancer, but just couldn't come to grasp with the need for an ostomy. And I looked him in the eye and said, I get it. I know what you mean. I have an ostomy, and he didn't know I had an ostomy. I surprised him with all of this. Not as much as I surprised the person who asked me about the chemo pump when I pulled that out from underneath the white coat. Probably should have mentioned that a little bit sooner before I did that. They did come back to see me, which was good, though. But I was able to tell this patient what it was like to have an ostomy and go through on a day-to-day basis of what this life is like. And he went on to have the surgery he needed to have, and to this day, he's doing well with his ostomy, but he's doing well. And I can't think of something more rewarding than be able to have that kind of relationship with my patients now. And so to be here with you guys is just an incredibly moving experience, and you're going to have to beat me away with a stick if you think I'm not coming next year. I don't need to speak, but I'm going to be here. So I'm going to speed up some of this because I know we're a little bit behind schedule, some of the general background, but I want to take a little bit of time to talk about kind of tumorigenesis and the fact that not all colorectal cancers are the same, and that there's many different ways in which colon and rectal cancers form, but in a lot of ways there's some similarities in that in general things start as a benign polyp, and this is why screening is so important, because there is an opportunity in the vast majority of cases for us to do a colonoscopy or some test in which to find these polyps early. And that in general it's over time that there's a somewhat sequential, though there's some debate about the biology of exactly how this happens, accumulation of abnormalities in the polyps or adenomas to eventually getting to the point where there's a cancer. And we think that the way that this process happens actually tells us a lot about the biology of the cancers, and I think will be important for us understanding treatment options down the road. And so as far as treatment options, so I'm from Wisconsin, and Charles Heidelberger first invented 5-FU back in the 1950s. And for the 1950s, 1960s, 1970s, all we had was 5-FU. There's many oncologists who made a career out of 5-FU versus 5-FU clinical trials. Should we give a bolus? Should we give a long infusion? Should we give shorter infusions? Should we do it 1 week every other week or multiple weeks in a row? It wasn't until the 1990s that we really got more other standard options, including oxaliplatin. Though it makes me feel like I have wet socks on all the time, I owe a lot to oxaliplatin and Folfox at this point. Capecitabine, and then in the 2000s some biologics, so bevacizumab, cetuximab, panitumumab, all being approved, and then now over the last 5 years or so, a number of other agents, aflibercept, ramucirumab, regorafenib, and most recently TAS-102 as well. And I think very soon to be pembrolizumab for the MSI high population as well. And with these therapies, we've seen advances. So before 5-FU, the average survival for patients with metastatic colon cancer was only 6 months. With each individual drug that was developed, there was an improvement in the overall survival, to now the average overall survival being in the years. So the most recent studies, average survivals of 3 years or more. And so the big question is now, how do we make improvements here, and how do we make not just incremental improvements, but how do we make big improvements? And so a big part of this, I think, is not looking at each cancer, or not looking at colon cancer or colorectal cancer as one big group of cancers, but now actually really starting to individualize the types of colon cancer. And there's multiple different groups looking at many different ways of doing the subtyping, but we'll all have the same goal of, let's understand the biology of what we're doing here. Let's not just use drugs that target cancer in general, or dividing cells in general, but let's actually focus on the biology of what's actually going on here. And so to focus this and understanding the biology, there's two major paradigms that are both looking to make advances in colon cancer, that being precision medicine and immune therapies. So precision medicine, basically looking at biomarkers within the tumor, whether it's mutations or other markers, as potentially predictive of certain therapies. And then also immune therapy, so trying to harness everyone's own kind of immune system to target the cancers. So in precision medicine, there's actually been some recent advances for certain subtypes. And so over the last few years, we're learning more about the BRAF mutant subtype, the HER2 amplified subtype, in addition to the MSI hub subtype, which I think we include in the immunotherapies as well. And one thing that my lab focuses on is, well, what other types are of interest? And right now we're pretty excited about PIK3CA mutant colon cancer as a potential targetable subtype. So we actually make mice that possess many different mutations in their colon and develop colon cancer. And I do mouse colonoscopies on them. Not exactly what I thought I was going to do when I got into this. The secret with mouse colonoscopies is that the mice will only drink Go Lightly once. So, so the only way to do it is actually by enemas, but we figured that out. I don't know what I did now. Anyway, we don't need that. So then oh, there we go. Thank you. So then the other category being the immunotherapies, and the immune therapies with the MSI-high or mismatch repair deficient colon cancers in the anti-PD-1 therapies is really a great advance, and I think it's only a matter of a very short period of time before there will be FDA approval for anti-PD-1 therapies for MSI-high cancers. The downside for the vast majority of people is that this is a pretty small population. So only in the metastatic setting, it's really probably 3-4% of patients. And the good news is about 60% of those patients will respond to these types of therapies in the current clinical trials. However, that leaves the other 98% of people to not have immunotherapy options currently. And so how can we bring that forward? The exciting news is because of the advancements that have been made in the small population, there's a large amount of enthusiasm with bringing these types of therapies to colon cancer in general. But it's not going to be as simple as it has been for the MSI-high population, meaning it's not going to be just one drug that is going to allow us to make a big response. But it's going to be combination therapies. So whether that be with colon cancer vaccines or personalized vaccines, or in combination with other things that help augment the immune response like radiation therapies. So there's a lot of clinical trials in development, and as part of the NCI task force that I sit on and multiple of the cooperative groups, the number of immune therapy-based clinical trials that are coming is really exciting. So that's going to be a huge advance that we see in the near future. And so just to talk more about kind of the advocacy role here, in that there's a lot going on right now, and it can be overwhelming, but the role of the advocate in helping bring this work forward is critical. On a recent conference call for one of our cooperative groups, we were going over different immune-based therapy protocols for colon cancer, and there are many really exciting ideas out there. And the big question became, how can we move this work forward? And the top 3 answers to moving this work forward is funding. And so that, I know one question was brought up earlier about what can we do, beyond funding and things like that. Funding is really important, and that is a huge thing. Raising awareness, educating people about the needs for research and the needs for funding, and really being here and using your passion. Part of the reason why this first session was so moving was hearing everyone's story and everyone's passion for the cause. And there is a lot of power in your story. And stating your story with a focus, and a focus in a group like this, is an incredibly powerful asset that we have to fight colon cancer. And so again, I just really want to thank everybody for all the work that they're doing, sharing your stories, and good luck on the Hill, and happy to answer any questions.
So, Dusty, I did want to ask you, as well as others, when we think a little bit in terms of the initiatives and the legislative aims and ask, we have seen a decrease in funding over the last couple of years. Would you like to just say a few words about that before we move into the panel? Do you have it? Okay, sounds great.
So the decrease in funding has been has had an incredible impact on cancer research in general. There's multiple labs closing because of the limited funding, but another really important aspect is that for the NCI-sponsored clinical trial groups right now, when we run a study through any of the cooperative groups, all of those studies are underfunded, which means, so for me at my center, if I'm going to participate in one of these clinical trials and help get some of these new exciting drugs to patients, our facility actually has to pay additional money in order to make those clinical trials happen. And so it is absolutely critical that we have additional funding to do this. And I know there's been a lot of excitement lately with the Cancer Moonshot, and I think that, you know, any additional funding is great. What I worry about the Cancer Moonshot is that it's kind of a burst of funding, in that there will be some excitement, some new clinical trials going, but then that money goes away and there's no promise of future funding. And so what we really need is an increased amount of funding for a predictable amount of time. Really would help kind of make a big advance as far as stabilizing the current clinical trial infrastructure.
So thank you. I think that's really important for us, because I know we go into detail and we'll be talking a little bit about each one of the initiatives and how that fits. But I think that's a really nice overview to give people perspective. You know, just to give others a perspective as well, and I think, you know, in terms of even the work that I do specifically at university around survivorship research, you know, when we actually would see proposals that were basically approved for funding, that used to be when they would make basically the first cut about looking about scientific relevance and looking like sound proposals. When they made that first cut, typically we were seeing about 28% of the time they were being funded. We see that now at 6 to 7% of the time. So, I mean, we're seeing a dramatic drop in terms of what we're looking for funding proposals and to get the work really put into production, and it's taking a lot more effort, and I think it's very difficult right now to advance a number of the initiatives that I spoke of, as well as the treatment options and the work that Dusty's talking about as well. So critical importance. So to add to that conversation, we actually have three esteemed colleagues here with us today to talk a little bit about their perspectives and different perspectives on the research. And so, Rich, we want each one of these folks to do is go ahead and introduce yourselves. And we're going to hear from each one of them based on where they're from, with Tom as a stage 4 CRC survivor, as well as a investigator as well, in terms of looking at drug development and basic science. Sara with PIPC, who's going to talk a little bit about the partnerships to improve the patient care, which is a group that we've been working, and Kevy's been in close collaboration. And then Jane, who's the executive director of the Reagan-Udall Foundation for the FDA. So I'll let each of you introduce yourselves, and then Tom will have you go ahead and present. So.
My name is Dr. Tom Marsilje. Some of you may know me from online as Dr. Tom, or the currently incurable scientist. I've been doing drug discovery research for over 20 years, with a focus on cancer drug discovery research for most of that time. And most recently, the past year or so, I've become a pretty strong patient scientist advocate.
Very good. And tell them what you did yesterday. Time magazine.
Oh.
Yeah, wait till this, and the pause.
Excuse me, because yesterday I was flying.
No.
The day before yesterday, I got
right.
interviewed by Time magazine about CRC and immunotherapy.
Right, yeah. Yeah. So we were really excited about that. Sorry, I meant the day before. Yesterday was like, what? Yeah. But Sara, go ahead.
Sara Geertruyden with the Partnership to Improve Patient Care. PIPC is a multi-stakeholder organization that's very focused on themes of patient-centeredness. And primarily, we got started to advocate for the creation of the Patient-Centered Outcomes Research Institute, which you've heard a little bit about today. And that is an organization doing comparative effectiveness research in a lot of different areas. But I think what makes PCORI a bit different is that they actually give patients a voice and a vote at the table in terms of what research they actually prioritize and fund.
Very good, thank you. And Jane?
And I'm Jane Reese-Coulbourne, and I'm actually a 3-time cancer survivor, long-term advanced breast cancer, stage 3B, 25-year survivor, treated on a clinical trial and have had no recurrence, but have since been diagnosed with melanoma, and I'm 1 week out from my thyroid surgery. I lost my thyroid last week to thyroid cancer. So I've been part of the breast cancer movement back in the 90s, worked at the National Cancer Institute, and I'll talk more about some of the interests that I've had in research and sort of how we got there, and then some ideas about where we might be in the future, some things to think about.
So very excited to have all three of these folks with us for the interesting perspective that they bring. So Tom, I think we'll go ahead and have you with the Tom slide deck, and we'll hear from you first.
Okay, if you'll bear with me, I hate podiums, so I'm going to stand aside a little bit. Oh, perfect, thank you. Okay, so you heard my basic background, but I really want to start with a cancer life. Because my earliest memory just about is when I was from about 3 years old. And my grandpa Herb, he was a long-term rectal cancer survivor, and he had a permanent colostomy. And I can remember as a little 3-year-old finding out that my grandpa Herb pooped in a bag. Now, when you're 3 years old, you have no frame of reference, so it didn't mean anything to me. I just knew that grandpa Herb pooped in a bag. But I think it's really interesting that basically my earliest memory is of rectal cancer. And as I went through childhood and early adulthood, more and more family members had cancers of various types. We're very much a cancer family. And that really culminated when I was in graduate school, when my mother was surprised diagnosed with stage 4 pancreatic cancer. Now, for those of you that don't know, pancreatic cancer is just one of the most aggressive cancers there are. At the time she was diagnosed, there were exactly 0 FDA-approved therapies to treat it. She did take chemotherapy to reduce the pain, but me and her would talk about how you know when you're in a bad situation when they give you chemotherapy to feel better. But that was really a watershed moment for me because I was a caregiver for her, and along with my sister, I was an end-of-life caregiver for her. And so it really showed me that side of the cancer coin. And I had already planned on going into cancer drug discovery before she was diagnosed, but my mother's diagnosis really hypercharged and supercharged that. And it became a real mission of my life to become a cancer drug discovery researcher and to really try to make a difference. You don't go through that kind of situation without it changing you for the rest of your life. So I became a cancer drug discovery scientist. And for those of you that don't know, I think you do probably, cancer drug discovery is very, very difficult. Realistically, when a scientist goes into it, realistically you hope to have exactly one FDA-approved drug that you had some part of make it to FDA approval. That's how hard drug discovery is. And I was really lucky. As a pretty young researcher, I became involved with the project that did eventually become FDA approved for lung cancer. And it was a huge team effort, and it really was a wonderful thing to be a part of. And I can remember the exact date. Its clinical trial results were released at ASCO. And so ASCO is the world's largest clinical oncology meeting. It happens in June every year. And it's where the major clinical trials are released. And I remember the date. It was June 4, 2012. About 6 a.m. Pacific time, because I live in San Diego, they made the announcement at ASCO. The clinical trial results were amazing. Had almost a 100% clinical benefit to this subtype of lung cancer. And at 6 a.m. that morning, I was walking on air. It was a pinnacle of my career. But more importantly, I really felt as a person I had made a difference against cancer. It was one of the best days of my life. By chance, I had a colonoscopy scheduled for the exact same day. So 6 hours later, at about noon, I went for my colonoscopy, and they knocked me out for it. And I started waking up, and I still couldn't open my eyes, but I could start to hear. And I heard my gastroenterologist tell my wife next to me, "Your husband has colon cancer. We need to schedule emergency surgery immediately." Within a 6-hour time frame, I went from one of the best days of my life to the absolute worst day of my life. In a 6-hour time frame, I went from being a cancer scientist to being a cancer survivor. And since then, I've become an advocate. And I want to start out by talking about what is a scientist's view of research. And what I use to compare it to is a shark frenzy, because it really is a frenzy right now. And this all changed about 5 years ago. As I said, I've been looking at cancer research for over 20 years, and everything changed approximately 5 years ago, because a number of things all came together at once. You had high-power computing, you had high-speed genetics, you had targeted therapy, and very importantly, you had immunotherapies. And what happened about 5 years ago, where in very carefully controlled clinical trials, reproducibly, in a subset of melanoma patients, they were converting this subset of melanoma patients from stage 4 with very dire prognoses. Prognoses, I hate to use the word terminal, I don't use it for myself, but these were very sick patients. They were being cured. Over 5 years later, they are living with no evidence of disease. And this changed everything. Immunotherapies is an obvious idea. Use your own immune system to fight the cancer. It's one of those things that scientists have wanted to do for over 100 years, and it's easy to say, but it's very hard to do. But what happened in the scientific community is that once you had proof that there was a strategy where it could work in a subset of one cancer, that tells you the strategy has legs. And what you have to do is you have to do a lot of research to expand the number of patients it helps, expand the number of cancers it can help. And that set up a frenzy that I've never witnessed in my 20 years, where immense levels of funding, both public and private, have gone into immunotherapies. Companies normally compete against each other. They are businesses, but they start working together because for combination therapies, as Dustin mentioned, which are needed for a lot of cancers, they would have to combine drugs from different companies for clinical trials. And I really look at it as scientists all know people with cancer. They have cancer like me. They have family members with cancer. And they saw cancer's blood in the water. And they all want to cure cancer. And it just went crazy. It's just been amazing to withhold. It's been a complete frenzy. It's a very exciting time to be a scientist. You can feel excitement in the air when you go to cancer conferences now, where they're working for cures using currently used backbone drugs like PD-1 inhibitors. It's an exciting time to be a patient if you're forced to be a patient. But kind of the flip side of that excitement is it's a negative. And so a couple weeks ago, I did a search on clinicaltrials.gov for colon cancer clinical trials, currently accruing interventional trials, and there were 1,200 hits. And there are some really good trial finder services from the various advocacy organizations that reduced down that number to more in the dozens. But as a cancer scientist, I saw that number and I got intimidated. Where do you start? And if you're a person who doesn't come from a cancer science background, what do you do? Where do you start? And unfortunately, in many cases, and not most, cancer patients are having to find clinical trials themselves, or at the very least, they're given an option from their medical team to yes or no and make decisions on. And they're making these searches, and I look at it as a deer in headlights problem, because they don't have a scientific background, and it's just not an ideal situation. And so I decided as a scientist and a patient and now an advocate that I want to do some things to try to help with that situation. And so I was very, very excited when I first started working with Fight CRC on a monthly science column called The Currently Incurable Scientist. And the whole goal of this column, comes out once a month, is to look at major clinical trials for colorectal cancer and explain the science behind them, to basically educate the patient population. And I always include hyperlinks to the underlying scientific and medical literature so they can print them out and bring them to their oncologist. Because what I was finding is that even at the local oncologist level, a lot of clinical trials aren't that well known. It's been very popular. This particular post had over 750 shares on Facebook alone. And I wanted to use it as an example as well. The title of it is Releasing the PD-1 Breaks in MSI-High CRC Patients. Because as Dusty mentioned, about a year ago at a major scientific conference, a medical conference, a clinical trial was announced where there was a very high response rate if you're MSI-high to PD-1 immunotherapies. So all scientists knew about this. All oncologists at major medical centers knew about this. It is going to change the practice of medicine for MSI-high CRC. The problem is it wasn't filtering down to patients, and it wasn't filtering down to the local oncologist level. And so I very much made a cause last fall to really broadcast the PD-1 inhibitor trial news to as many people as I could. Because for this patient population, albeit they're minority, this will really change the practice of medicine for them. So I was very excited and proud that this particular PD1 post was shared over 750 times on Facebook alone. In a similar fashion, I also write a personal blog. It has a similar goal as my Fight CRC column, but it has a broader scope. It's called Adventures in Living Terminally Optimistic. And the real goal there is I have a unique perspective. I'm both a cancer scientist as well as a patient. And I can talk to both groups. And unfortunately, both groups are impacted by cancer, but they don't talk to each other that much. And the goal of the blog is to really explain science and talk about clinical trials and medicines to the patient population in everyday language. And there are so many exciting things going on in the scientific world to really inspire and give them hope. That is a huge goal. And on the flip side, I have a lot of scientist readers. And I also write brutally honest posts about things like chemotherapy and side effects, about losing friends to cancer, recently Lindsay. And this I do to really try to inspire researchers to remind them how important their jobs are and to really have them get the personal investment to work as hard as possible. So it's taken off. It has about 50,000 hits per month. It's in 4 languages now. And for PD1, I'd like to say in the Chinese version alone, the PD1 Chinese blog post had over 20,000 readers. And so even though it's only 3 to 4% of the population, I really hope to think that it impacted some lives in a number of countries around the world. So that kind of talks about how I envision, or how I look at things from a scientist level and an advocate level. But what about a patient level? Because I'm a patient too. And I wrote a blog post a couple months ago about my return to chemotherapy. So I'm currently on full fury chemotherapy. And I'm actually going to read it. And it's called Time to Tread Some Water. Sorry for looking down for this. The reasonable, plausible, and logical possibility of an immunotherapy breakthrough for the MSS subtype of CRC, the type I and most CRC survivors have, within a 5-year time frame has caused an earthquake-sized impact in the CRC patient community and is actively affecting treatment decisions, my own included. Now for many, there's an added perceived benefit of, quote, making it long enough, unquote, to make it to that, quote, immunotherapy breakthrough, unquote, the timing of which no one can predict accurately. And you need to underline verbally, like I did in writing, the word possibility. Because this is all science. And science is, by definition, doing things that have never been done before. So there are no guarantees, and no one can tell you when exactly that breakthrough will happen. But it is impacting my own treatment decisions and people around me. Because I think even though there's no guarantees and timelines, and even though MSS-CRC is much harder than MSI-High to treat with immunotherapy, looking at a situation where their breakthroughs are coming so quickly, and it's not hype when you read about the newspapers, and an immense amount of resources being thrown at it, both public and private, you can make a logical argument that is within a plausible chance of happening within a 5-year time frame. And all of you know how important that 5-year time frame is for the stage 4 community. So how does that translate to what we're doing this week? Well, I picture the coming immunotherapy, whenever it arrives for MSS-CRC, as a cavalry, of scientific cavalry coming to save the day. And what keeps the cavalry going is really research funding and research being funded by that. So what I want you to picture when you're on Capitol Hill and talk about research funding is you're asking for money to really keep this cavalry charging full speed ahead, to arrive in time for me, for people in this audience, for thousands and millions of people around the world. That is the real impact of research funding. I can hear the hooves in the distance. As a scientist, we are close, the blood is in the water. We just need to make sure that the funding is there to get them here as fast as possible for all of us. So thank you.
Oh, there's me. So my name is Sara van Geertruyden. As I said, work with the Partnership to Improve Patient Care. We are an organization that largely focuses on policies that put patients in the middle, put patients at the center. Policies to engage patients, and that's how Kiwi and I got to know each other. Last year, we held a roundtable for a group of oncology patient groups to talk about issues, and I was really, it was really a fortunate experience for me because I learned so much about this community and what the priorities are for this community moving forward. And I just applaud all of you for everything that you're doing And you're absolutely right. Telling your story is just such an important piece. I used to work on Capitol Hill as a staffer for a member from Louisiana, and I remember in those days when a constituent would come in with a personal story, that was often the thing that put me over the edge of, all right, we need to sign on to this bill. And I would get very excited, and I would go to the chief of staff, and it was much more so having a personal touch and a constituent with a personal experience that made me get excited about wanting to get my member to sign on to a bill than somebody coming in and telling me about all the technical reasons why it was important to do so. So I applaud you for being here because you're really making a huge difference. And this is a great organization, so kudos to all of you. So PIPC was founded in 2008, again, around the creation of the Patient-Centered Outcomes Research Institute. That's very important, too, because as you think about funding, what makes PCORI special in large part, too, in addition to the great work they're doing on comparative effectiveness research, is that PCORI is an organization whose funding stream is not from the appropriations process, right? Every year we go through this fight with Congress about NIH funding levels and all the other government agencies. But at PCORI, there's actually a set amount of money that they get each year through a tax on health plans. It's like $2 per plan. And that funds something called the PCORI Trust Fund. And that's the money that then they use to do research. And that's a very special funding stream. It may not make sense to you why it's so special, but it's a big deal because it's not something that has to be renewed every year. You don't have to go up there and lobby for it every year because it's there. But what's special, too, about PCORI, I think, is the work that they're doing to try to translate, to put the patients at the front of making decisions about the research that's being funded. And what is interesting is how much other research organizations, including the NIH and others, are now mimicking some of their patient engagement strategies to try to make sure that that information is actually useful downstream. So PCORI thinks a lot when they fund research about, is this something that patients will be able to use at the point of healthcare decision making? And I think more and more you're seeing that become the norm among the research community, whereas it used to be, answering novel questions. I think more and more now, because patients are so engaged in these discussions, patients like you, it makes a huge difference in terms of what kinds of research is being funded so that it is research that is ultimately meaningful at the point of care. So in terms of achieving outcomes that matter to patients, ultimately, I think, one of the key messages I would encourage you to have when you go to Capitol Hill is to make it understood among staff how much good evidence leads to outcomes that matter to patients. So some of the things that we think about at PIPC are the range of endpoints, care outcomes, and treatment goals that matter to patients, factors that influence differences in value to patients within populations, differences in perspectives and priorities between patients, caregivers, people with disabilities, consumers, beneficiaries, and how patients want to be involved in their health care, and how they want to do shared decision making, and what supports shared decision making. And when you think about policy and research, right, one of the things I've always been really impressed with here is this RATS program about building the capacity of patients to be engaged. I can't tell you how many times I get a phone call from someone saying, hey, can PIPC help me find a patient? I need a patient to participate in XYZ. And I go, oh, okay. And, I sort of pick up the phone and start calling everybody I know to try to find a patient with an experience that's relevant to that, whatever that committee meeting is or technical advisory panel. And sometimes, unbelievably, it's hard to find that person that's able to do that engagement. Or to find, and it's probably not as hard as I think it is, but I think it's just finding the channels to get to those people that can sit down and meaningfully engage on these issues. And so the fact that you're here and that you're going through this process is just huge because you have so much insight now about how the process works, right, that I bet a lot of your colleagues don't. And that makes you an invaluable resource. So I would encourage you to do this often. It's very important for patients to be here doing this often. So when we talk about what it means to have patient-centered research, obviously engaging patients, one of the things that PCORI has done in their research is they've set up something called the Patient and Family Engagement Rubric. It gives suggestions to researchers about how patients should be engaged. And I found it fascinating. I'm on the Patient Engagement Advisory Panel at PCORI, and there was this conversation we had at one point about, so we have all these researchers telling us that they want to engage patients, but they don't want to have to pay patients to be engaged. They don't want to have to give them any sort of compensation for their engagement. And so it started a really interesting conversation within our group about, well, and I'm not talking about subjects of the research. I'm talking about patients that would be engaged in helping to design the research project, thinking about what are the outcomes that we should be measuring that would be meaningful in this project. You know, do we want to just measure 5-year survival? Do we want to measure fatigue? Do we want to measure whatever it may be? And so that's the level of engagement I'm talking about. And so, of course, you know, as we came around and talked about it, we said, well, that engagement in and of itself is just as valuable as the scientist's engagement, or the researcher or the clinician that may be engaged. And so we came up then with a whole rubric for how patients can and should be compensated for participating in research at that sort of design and implementation level. But it's fascinating to me, and this is just sort of gets at the change that's happening in the research world, how patients are engaged in research, how then that research feeds into shared decision-making tools. One of the things that I think all researchers struggle with is this, you've got the research, it comes out, but why is it that it takes so long for it to get into practice? And that's something that I think the field is struggling a lot with right now. And one of the things that we've been saying as PIPC is, well, what would be very helpful is for you to engage patients in that dissemination process. Research shouldn't be just published in a peer-reviewed journal. Patients aren't reading peer-reviewed journals. Clinicians are often not reading peer-reviewed journals. Let's create a shared decision-making process where all of this great evidence is translating into something that's meaningful and usable at the point of healthcare decision-making. Thinking about how you make those tools accessible then to patients, communicating clinical value and patient health outcomes, not sort of these one-size-fits-all value assessments. As PIPC, we've been very engaged lately in this discussion about value. I participate in something called the Consumer and Patient Affinity Group, which is part of this value agenda that they have over at CMS. But the long story short is that we are talking about value a lot in healthcare, but the missing piece is value to who? And what we keep kind of trying to come back to is, shouldn't we be talking about value in the context of value to the patient? And how are we going to achieve outcomes that matter to patients, which is value to the patient, if we're not giving patients good information about the impact of the various treatments on what they care about? And sometimes it could be, sometimes it could be a survival, it could be a more of a quality of life indicator, it could be so many different things, but symptoms are always part of that equation, but I think sometimes or at least based on what I know, sometimes get lost. You want research to, of course, always reflect diversity, and to be technically excellent and appropriate, open and transparent. So, I don't want to belabor this, but I think you get the picture about what it means to be patient-centered. And what this all boils down to is changing the culture of research, and that's why your engagement is so incredibly important. We're learning a lot from PCORI in terms of how we engage patients to make research more meaningful and usable at the point of care, how we compensate for patient engagement. But it's also, looking at those quality of life indicators and comparators and usability, and making sure ultimately that it's usable and that we're using it for shared decision making. So, and I'll just end on, I hope that everybody here stays engaged, does this again early and often, and that, we really do work toward making sure that we have good, credible evidence that changes the practice of medicine, by making sure too that that evidence is accessible, not just to your clinician, but also to you. Thank you.
So I assume this works. Okay. So I'm bringing up the rear here, so to speak. And I have to say, for me, it's been a really interesting part. I've only been here about half the day, but it's been really good for me. I haven't hung out with a group of patients for a while, and like I said, I'm a 25-year late-stage breast cancer patient. They gave me 2 years to live in 1990, So I say that for those of you who've been diagnosed with stage 3B, which is what I was too. I was inoperable. And I went on a clinical trial, and there are 2 of us who've still not had any recurrence. We don't quite know why, but you know, somebody makes up the other end of those numbers. That's what I kept trying to think about, you know, when I was diagnosed. In more recent time now, actually, let me go to this. I've now been diagnosed, you know, besides dealing with, you know, I had high-dose chemo, high-dose radiation back in the day before the good antiemetics, so that was really fun, and gave myself an injection of GM-CSF every night because that was part of the protocol, trying to get the bone marrow to come back and whatnot. But in the last 2 years, or actually in the last year, last 12 months, I've been diagnosed with 2 new cancers, melanoma and thyroid cancer, which, like I said, I had surgery a week ago, but I felt like this should be my coming out party from my surgery. What better group to do it with? And so I'm really used to and understand late effects. I could go on for quite a while about those, as well as being diagnosed at a fairly young age. It was a couple days after my 36th birthday when I was diagnosed with late-stage breast cancer. So here I am, 61 years old now. I feel like Methuselah a little bit. But I've been here through and been up on the hill a lot. Just makes my feet hurt thinking about it, all the walking on those floors. Wear really comfortable shoes. That's my best advice. I ended up walking barefoot through half the day because I couldn't stand my shoes anymore. It's a tough place. There's a lot of, hopefully you did your Senate first and then House or vice versa, not back and forth. It's a lot of walking. But it really is worthwhile telling your story. As you know, our colleague up here said, it really gets people's attention. And just being yourself and telling your story, sometimes they can't even really believe that you've been through all that you've been through, or, you know, with a family member or yourself. It really does have real impact in all of this political craziness that's going on right now. So after I was diagnosed, I'm actually an engineer by education. I'm a chemical engineer and was off doing chemical engineering type work at Procter & Gamble, bringing you things like Dawn dishwashing liquid. How exciting, right? And then after I finished treatment, I ended up helping to start up the National Breast Cancer Coalition. And for those of you who don't know that group, back in the early or mid-90s, had 600, still does actually, 650 different groups we brought together. It's kind of a sloppy coalition, but of people interested in breast cancer. And I would say, you know, I was thinking about listening to you all today about going up on the Hill together. The people on the Hill must be hysterical and excited because they get so tired of the breast cancer groups not only coming up separately, but having different agendas, sometimes in conflict. So they're just kind of left with, what do we do with that? So the idea that you would all come together is really, really important. So I went to work for the head of the National Cancer Institute, Dr. Klausner, for about 4 years, and often gave him patient perspective on a number of different trials that they were unblinding and whatnot. And I've worked on a lot of expanded access programs, some in colon cancer, actually. The oxaliplatin one before it was actually came on the market. So expanded access is early access to a drug before it's actually been approved by the FDA. And so that's something I'm probably going to be continuing to work on now with immunotherapies and some other things, but also secondary use of a drug that's maybe already been approved for a particular cancer, but may be useful in another cancer. And I'll talk more about that. And then for the last 6 years, I've been running the Reagan-Udall Foundation for the FDA, and that's a 501c3 not-for-profit created by Congress to help support the scientific mission of the FDA. And so we've been working on really large science projects, if you will, that require the government, industry, not-for-profits, academia to work together to accomplish that. And so I'll talk a little bit about one area of that I think you might be interested in. So I've always thought, even back in the early 90s, that cancer research is really advocacy. And that's everything from doing what you guys are doing right now, going up on the Hill and trying to get more funding, which is even a bigger deal. And when I worked at the NCI, I was joking earlier, it was during the fat, dumb, and happy period where we doubled the budget. The good news about that is we got a lot of money to put a lot of research in play. But the downside of that, and that could be what folks are talking about with Moonshot, is it sets an expectation that that's all you need. Well, we doubled the budget. How come you don't have the cure yet? And so I caution you about it's always a tough balance between we're making all this progress, we need this much more money to get more progress, and sometimes people thinking, okay, we just did X, so now we're going to move on to something else. And so you always have to balance that and explain about how research works. But also setting research priorities, and that's where some of the folks, I think, that are at that RATS program that you've been doing, I think the idea of a seat at the table, whether I know Nancy Roche sits on the, I think she still sits on the NCAB, National Cancer Advisory Board, lots of big advisory boards that are thinking through how do we want to spend federal dollars on research. And so having a patient at the table is really, really important. Actually participating in clinical trials like myself and others, where you just go on, you know, they're not for everybody, but I think everyone ought to consider it, whatever their situation is. I've actually been on a couple different ones at this point. Also found out that I carry one of the breast cancer genes, which may explain a number of things. And then participation in things like expanded access, and there's going to be a lot of new kinds of trials, new design trials coming down the road, so something people might be interested in. So as you talk to all of your family, friends, and others, sometimes saying to them, you know, you ought to look at all your options, and participating in research is an option. And then make sure they know about it, and then after that, obviously, it's up to them and what they want to do. Improving the regulatory process, I've spent quite a bit of time working on that. That is not exciting, and it is not fun, but it is really important, trying to get, and I'll talk about the drug development process in a minute, and about how the regulation, at least that part of the regulatory world that I'm talking about. And then advocating for new science, and that can be really important in a number of ways. There we go. So I just took a shot at creating something that's really the drug development process, but as you look at each piece of it, you can actually see where patients are important in all of it, whether it's being on a clinical trial, raising funds for a clinical trial, getting information out, educational material. I mean, we've been working on, collectively, the advocacy community have been working on refining and improving these roles and seats at the table for all of these different parts of the process. And I even threw in a few statistics about, you know, how many compounds you have to start with to get one out the other end. And so I think it was Tom said, you know, it's a slow process. It's not a quick process, but patients really do help improve that process. And I think some of the things that you learn in the RATS program and sitting at the table will be really important. So today, I thought I might try to think about new science a little bit, from my perspective anyway. One of the things we've gotten involved in Reagan-Udall is big data, which is kind of not really even a term, really. It's something somebody made up that kind of encapsulates everything that's going on right now in data sets. But as you start to look at these very large data sets, for instance, the FDA has a data set that's made up of electronic health records and claims data, but it has 180 million people in the data set. That's a lot of people. So as we start to think about moving toward personalized medicine, aren't there ways we can go back and mine some of this data? I mean, think about how much data must exist right now. Just thinking about the FDA system. So one of the problems is, though, technologically, it's not such an easy thing to go back and look at all these disparate sets of data that have been thrown together. You can throw them together, but you got to figure out the methodology to really be able to go in and see what questions can I really answer, what can I validate. It can send you on a lot of false positives and false places. So developing methodology is one of the things that Reagan-Udall has been working on, which is bringing together all of these scientists who do this. And it tends more toward the engineering end of the spectrum, which is probably why I like it. but trying to figure out how do we actually use this data in some reasonable fashion. So big data efforts are going on all over the place. PCORnet, which is part of the PCORI system, is pulling together lots of patient data. And so one of the things, that's one group. The Sentinel system, which is the data set from FDA that I was talking about, there's like about 180 million people in it. NIH has a big data to knowledge initiative. They're also pulling things together. And then ASCO has something called CancerLink, and what they're doing is they have access to about 75,000 oncologists, and what they're hoping to do eventually is have all of that patient data, de-identified and whatnot, pulled together so that we can start looking through it. Well, when we start to figure out how to deal with this data and how to pull it together, and we now have technologies that are going to lend themselves to that, what's going to be really interesting is we're going to start to find subsets of people. So we started to see some of that now. You know, if you have the KRAS gene, that's, you know, there's certain molecularly targeted drugs that are probably going to be more useful for you than somebody who doesn't have that. Well, think about the gazillion different kinds of, you know, as we get into personalized medicine, there's going to be more and more and more of these. What if we could go back and look at existing data and start to find some of these, or at least generate hypotheses about them? I don't know that we'll be proving anything, but wouldn't it be great, rather than just starting from scratch, if we could go back and we could start to see trends in the data that are going to tell us some of these things so that we know where to look. And then we can start running different kinds of trials. So one of the things we've been looking at is how do you figure out the methodologies? How do you do predictive modeling? How do you take out the noise in the system so that as we start to look at these different sets of data, we're able to actually make sense out of them and make them useful? Well, I start to talk about other sources of data, payers, providers. Think about all this patient data that's out there. Unfortunately, it was all collected for different purposes. And so, you know, it's not all apples and apples, it's apples and oranges. And so there's actually a whole area of technology that's really trying to figure out how to make sense out of all of this. And I do believe we will make significant progress. So what does that mean from an advocacy standpoint? So as we were putting together one of our big data initiatives, working with the FDA, I, you know, being a patient advocate and a patient, thought, okay, I need to make sure I have patient advocates that are at the table as we're coming up with these projects. And I know a lot of cancer advocates, because not only did I work in breast cancer, I actually was the executive director for about 6 months when Carly, I knew I'd recognize you, left. And I've worked in, so colon cancer, lung cancer, I did a turnaround for that group. So I've worked in a lot of cancers. I know a lot of survivors and advocates. And I was having a hell of a time finding anybody that would come sit at the table. This is really complicated stuff. People are intimidated by the science. And so I did manage to strong arm a couple people to be on it. But then I thought, okay, this is crazy. This is just like when, you know, in the mid-90s, when we were at the National Breast Cancer Coalition and we said, we need a seat at the table. And then we quickly figured out, we had a room like this, and we went, gee, there's 5 of us trained in the science to really sit there and be conversational. And so we said, oh my God, we need to train people. So we came up with this program called Project LEAD, which was a kind of like a Berlitz course in the science of cancer to help people get the training. And then if you had and so there are a lot of people out there now. There's a reason why in breast cancer there's a lot of folks that have been working in science for a while, because they got that training and they've been practicing all those years. So I'm like, well, why don't we do the same thing and start to get some data folks, people that start to understand data who can sit at the table. And we got interest from FDA, NIH, the pharma companies, you name it. People are like, you train those folks, we'll take them to sit on panels. So we actually got a grant from PCORI, or an award, they're not really grants, an award to create kind of a Berlitz course in the science of data, and to help people understand what that means and kind of how to apply that information. You don't need, you know, it doesn't matter whether it's about data or clinical trials. To sit at the table and to really provide your perspective as a patient, you don't need to be a full-blown scientist. You really don't. You need to be what I call conversational. And that's what I think I am in clinical trials. I mean, you wouldn't want me designing a clinical trial, trust me. But I can hold my own in a lot of good discussions about clinical trial design. Now, I've been doing it for a while. But it's a matter of I'm interested, I want to sit at the table, and I'll just keep learning, and I ask like a million questions. I'm sort of a pain when it comes to that. But so what I'm advocating is if this is something that you're interested in, or some faction of people, not everybody will find it interesting, but whether it's learning the biology piece, the RATS program, I think, is a really good start from what I understand about it. The program that we're talking about will be open to anyone who wants to take it. I think the first course is going to be in the fall. We're developing that right now. But that's another whole line of science that will be really important going forward. So I encourage you not only to think about that as an individual, but as organizations. There were two things everybody said they really needed when I talked to advocates about this training. One was everybody's coming to us asking for our data. And we don't understand enough to feel comfortable about who we should give it to and what we should watch out for. And so I think the more you understand about this, the better you'll be able to answer those questions for yourself. But the flip side is, what about the opportunities this data is really going to provide going down the road? If we don't understand it, we're not going to be able to take advantage of it. And so I think for those two reasons, I'm hoping that more advocates will get interested in this particular area, whether it's from a policy standpoint, funding, trying to get additional funding that goes down this road, but also from a personal standpoint to better understand it. It's also useful on a personal level as you look at, if you're like me and, if things go well, you're a 25-year survivor, you're constantly looking at that kind of information. So I think on that note, I kind of talked about this. Sorry. I'm going to go to thank you. And I mean that not only personally for I know it's been a long day, and some of you got up very early to go to the NIH, which is always a fun trip out to Bethesda in the rush hour. So I appreciate that. But I also appreciate everything you're doing and all the energy you're putting into it, because I know you've been affected by cancer, but that doesn't mean lots of people have been affected by cancer and they're not doing what you're doing. And so I very much appreciate that. Thank you.
Okay, everybody, we have about 5 to 7 minutes for questions while we have our panelists here. So Dusty's going to moderate this session. I just want to say the shameless plugs for RATS, sensational work. We didn't even pay them to do that. So really appreciate that. So Dusty, so if you have questions, come up to the podium, wind it up quick so we can have really good discussion and get this going.
I'd first just like to thank all of the presenters. It's really interesting to see the different perspectives, and so thank you for coming and presenting. What questions do we have?
We all know that the government has been cutting back and not increasing funding, but what about the private sector, the nonprofits that are out there fundraising and saying, oh, we're raising money for research? Have you seen an increase in funding from them, or a decrease, or is it level? Or?
So I'll start with part of that, and then we'll see if anybody else wants to. So there are definitely particular groups that have shown an increase in funding. The hard thing about that increase in funding is that it's going along with more groups looking for funding because the NIH isn't providing the funding that they used to. So an example of that is because the grant funding for basic science grants is down around the 7 to 9% range, there's more people applying for American Cancer Society grants, and so their funding range is now dropping. Not that they're not giving out money, but they're just having more applications because there's not other people aren't getting their funding from other groups, and so it's becoming harder across the board to get that funding.
Thank you.
There are more acronyms that I know, like, how do you find
So there's two different types of genetic testing. So there's genetic testing to look at a predisposition for cancer, or Lynch syndrome, BRCA, those types of testing. And then there's also testing looking at what we call the molecular profile, or mutations that are in the cancer itself. And that test in general is not approved by insurances for most patients. And so there are instances where it will be provided, though in many cases outside of clinical trials, we don't know what to do with that information. In general, KRAS, NRAS, BRAF, and MSI testing are standard of care for colorectal cancer, especially in stage 4 setting. But outside of the clinical trial setting, we're not exactly certain what to do with that molecular profile yet.
Would that information help to prevent recurrence?
So just in case people didn't hear the question was, would knowing the molecular profile of your cancer help in any way as far as preventing recurrence? And the answer right now is that there are some mutations that are associated with a better or worse prognosis, meaning they might change the odds of the cancer coming back, but we don't know as a standard of care what to do with that information yet. And so it at least in the current setting doesn't change what we recommend.
The only thing I would add to that was in terms of immunotherapies, MSI is the acronym I use, and I think Dustin used as well, MSI high, versus non-MSI high. And if that's not already, it depends on the hospital, if it's not already on your pathology report, that is a test that is pretty standard in pathology circles, and something that can be requested. Mm-hmm. And the word of mouth I'm hearing back from the stage 4 patient community is that insurance is covering it. And that really, it does impact the use of PD-1 inhibitors currently in the trial setting.
So the MSI should be of either MSI or immunohistochemistry for mismatch repair genes should be done as standard of care on all cancer patients, colorectal cancer patients at this point. And so that is being approved, and we still don't know what to do with the PD-1 therapies in the stage 3 setting, though those clinical trials are coming soon.
Sure. With all this funding and fundraising, is there accountability for where these funds go? How is that monitored?
Go ahead.
Give you my opinion. I also think that's part of the advocacy role is holding, government or whoever accountable. So there's lots of different levels of that. One is when you look at the NCI budget and you look at what NCI spends money on. Again, having somebody, I know Nancy happens to be on the National Cancer Advisory Board, and I'm sure there are other folks who are involved in other parts of the process. But making sure that money is spent the right way is, that sort of accountability. There are some people who believe that the structure of grant making ought to be a little different, so there's more accountability on the back end and less upfront effort on the front end. It seems to be very front-loaded, at least from my perspective. And so, there's definitely some concerns about that. Now, some of the private groups have come under scrutiny for how they spend their money, too. So I think in this time of there not being enough funding for things, I think that's one of the problems, or not problems, but that's one of the things that's going to be continuing to happen. So when you go up to the Hill or you go anywhere for funding, one is being able to make a case for why it's really important, very specifically why it's important for you to get what you need, but also to make sure that you really understand and you're not partnering with people who are spending 50% of what they raise on overhead, that sort of thing. And so there should be more accountability probably, but that's kind of what advocates really should be doing.
Yeah, I want to build on that point. Sorry, I'm not on the panel, but I'm just going to jump in. But as far as Fight CRC and what we do, and as an advocacy group, I think spot on what you're saying. That is the role of advocacy. That's that marriage between advocacy and these research dollars. So when you're asking for more money for the NIH and NCI, for example, tomorrow you're going to hear more about the DoD appropriated dollars. So that when we say that, you have to go out there and say colorectal cancer is a big issue. We want colorectal cancer to be on the table. That is a cancer we want you to fund. And it also speaks to the rats that are in the room. So we're placing them on grant review panels, and the value of that, and I just kind of want to make this practical, is that when they're sitting around a table with a bunch of researchers and they're talking about cancer and the science and the fascination with the science, I think what's very unique about having that patient voice at that table is it makes it even more real for the researchers. I mean, Dusty and Tom are unique situations where they have a personal connection, but I think it grounds those panels. So when then you're reviewing it, a survivor like Flo and Elaine and Nancy, they're sitting there saying, well, that's not what the patients really want. And I think that's why PCORI is so important, is that it's that voice, it's your stories, and it's just like going to the Hill and telling your member of Congress, we have to go to our research community and say, we want to be a part of this process, we want to have a voice, we want to be engaged, and we want you to know that we'll go to Congress and say we'll get you those dollars, because it's going to take hundreds of millions of dollars for the whole cancer community to be invested in this. And colorectal cancer has to have its own kind of focus and concerns, like the under 50 genetics, family history, survivorship issues that are unique to colorectal cancer, and we need those issues at the table.
I think that's a really good point, that when the patient voice is there, because I can't tell you, everywhere I go I hear a story about how a patient changed a research design because researchers or somebody, they were about to study something that patients were like, so what, right? And they were like, you're not measuring the right things. And so those examples are abundant. But what I think is really key is if you're partnering with the researchers and making sure the researchers know that they need to partner with you because you're their advocates. You're the ones that are going to get them funded, right? So if they're not partnering with you and you don't like what they're doing, what do you think is going to happen, right? So hold their feet to the fire, make them engage you.
And I would add to that, it's right now how groups are being judged is kind of what % of their money that they bring in is going to research. And it's not actually looking at the outcomes of that research or where that research money is actually going. And I think a question that advocates can ask on a lot of these grant or review panels is, what is the likely impact of this question that's being asked? And so I've been on panels where funding goes to groups because, you know what, we haven't funded something in that state for a while. Or, this prior group did good research, so maybe this grant that they have now is going to be good research, even though it might not be the most exciting or the most likely to have a big impact. And that's where having a patient voice in the room really stands up for the colorectal cancer population as a whole, saying, you know what, we need to really move the needle and not make incremental gains and not fund things based on things other than good science. All right, so I think that's the end of this session. Thank you, everybody, and thank you to our presenters.
How's your, I have a girlfriend on the hill who needs that.
I'm sorry, you didn't see my hand, but perhaps one question goes back to the genetic piece. Since we are working with since we are dealing with so many young adults now that are being diagnosed, what is your recommendation on, like, several of them have gotten screened, or genetic testing, sorry, and, they're wiping their brow and it comes back negative. Whew, okay, I'm tested negative for Lynch. However, when I encourage them, and sorry, I'm just a colon girl, I'm a nobody, I'm not a scientist, I'm not a doctor, but I recommend them to wait a couple of years and retest, because there's so many mutations out there that's not being picked up in certain tests right now. And we've had survivors such as Danielle, I'm sorry I'm throwing you under the bus, I hope that's not personal, Danielle, and Susie, and so many of them have retested and they do test positive for Lynch or something similar, so doctors then treat them as Lynch. So I just wanted to bring it up because so many young adults are thinking, oh, I've gotten genetic testing, whew, negative. But I'm like, you got to be your biggest advocate, and I want them to know that they may need to be tested again because it sets the guidelines for their family, for their future possible children, their siblings. Do you have a recommendation on that, or do you have thoughts? Am I telling them the wrong things?
So I'll take the first stab. I don't know if Tom, if you want to talk about this. And the big question is the kind of unknown unknowns. And the good news is that with the explosion of testing that's happened and the advances in testing in the last 5 years, that the tests are much better than they used to be. I mean, it used to be that we looked at 2, 3, 4, up to maybe 7 genes, and now we're talking about 200 plus gene panels. And so our testing is much better than it's ever been. I think the big question becomes, what do we not know about? And I think that especially in the young adult population, there is reason to think that maybe there's more going on that we don't know about. And what's the biology going to tell us in the next 10 years? I don't know. I do think it's important for patients to continue to get colonoscopies, to continue to get screening, to continue the conversations about genetic counseling, and to make sure that they're aware of other family history and things that may shed light on things down the road. And I definitely don't, though I haven't seen a national group recommend retesting, I think it's something that as advances in the science happen, we have to be aware of and definitely consider.
Because I just hear a lot of, I'm sitting in a class, excuse me, because I'm here. I need one of these to put in my pocket. Can we get that for that? I'm hearing a lot of, my grandmother had breast, my mom had this, I have colon. I'm hearing like Lynch, and again, I'm not a scientist, I'm not a doctor, but I really feel like the young adults need to be noticing that and not just going, oh, grandpa didn't have colon cancer, whoo, I'm good. Need to think about mom with breasts, ovarian, all of that. And I feel like that needs to be, we need to advocate on that a little bit more, educate them, so they understand what they need to ask for and be tested for.
It's a great point. Do you have a...
Crystal, we are going to be running shameless plug for webinars and education. So what PIPC, we are going to be running it probably this summer and fall, a little more about inclusivity, or basically looking at testing, panel testing, and then what to do with results and frequency and period of time. So that's something we are going to be covering with the genetic counselors, geneticists, as well as our physician base too. So I know we don't have time to go into it a lot, but we will be. And then what do you do with that information go forward? It's also going to be a huge part of our 1 Million Strong panel in Nashville. Shameless plug for Nashville for everyone to come and be on that. So that's going to be part of that conversation as well. We're also a commercial.
Go ahead.
So this is just from the scientist's point of view. I'm not a doctor. But what I find is that science is always evolving, and they're always finding new things. So using 2 examples, I was diagnosed with melanoma synchronous at the same time as a colorectal cancer. And most of my family has some sort of cancer, all different types. So this logically, there's something messed up in our germline genome. So that's the inherited part of the genome. I've had a whole genome sequence done. They cannot find anything with a currently known genetic marker. But science is always advancing, and this logically, there's something there. And so, as a scientist, I would say, as you hear about science advancing, keep that in the back of your mind that a gene panel in 2016 will not equal a gene panel in 2020, or maybe in 2017. And a patient story I love to talk about when I give talks is a woman from the lung cancer world. She was diagnosed 10 years ago, approximately, with stage 4 lung cancer, and given a very, very dire prognosis, I believe of less than a year. She happened to be the second or third person in the world on a clinical trial for a new tumor marker for lung cancer, and she responded beautifully. That was 10 years ago. She's a great blogger in the lung cancer world. This is 10 years later, after that initial prognosis. She's been on 3 clinical trials, and she just blogged that she signed her first 3-year lease in over a decade. That's how well she's doing. She still has stage 4 cancer. She's not cured. But this particular genetic marker did not exist when she was first diagnosed, and she is in the right place at the right time to be tested for it when a clinical trial was starting up. And so that's something to really keep in mind for everyone out there with stage 4 or worry about reoccurrence, et cetera. that science is always evolving. So.
Thank you. Thank you. I want to thank all our panelists.
Okay, I have a few housekeeping things for you guys. Does everybody know the hashtag really quick? What's the hashtag? Very good. A reminder, if you want to see your pictures up here, Twitter and Instagram, okay? Facebook, it's fun, but we can't feed it. Facebook's